Hello, everyone. My name is Anshu Biani, and I am co-leading the social impact track along with Sydney Hulabach. So in today's session, we will explore race, history, and the science of health inequities. To lead our discussion today is Dr. Vita Johnson, the Marcus Professor in General Academics and Pediatrics at the Emory School of Medicine, and she's also the Director of Partners for Equity in Child and Adolescent Health. In the chat, please feel free to introduce yourself and leave any questions for Dr. Vita Johnson. But without further ado, go ahead and take it away, Dr. Vita Johnson.
Well, hello, good morning. So when she was introducing me, I actually heard two separate voices. So if you're hearing me twice, let me know.
I'll definitely let you know, Dr. Johnson, but as of now, no one has said anything in the chat.
Okay, so it's like a feedback. It's sort of weird. So anyway, I'm happy to be with you this morning, and okay. All right, so I keep getting this feedback, but I'm going to try to push through. So thank you for allowing me to be a part of this conference today. I'm going to talk to you a little bit about race and health inequities. So I have nothing to disclose at this moment. And I'd like to start off by just defining what health is in the context of what we're going to be talking about. So the World Health Organization defines it best. They say health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or deformity. When we look at what the determinants of health are, we start with the genetic makeup or someone's DNA. We also look at someone's individual behaviors, such as whether or not you eat the right food. So if you exercise, so Anshu, I really can't, I keep getting this feedback. And so I'm hearing myself repeat it. And so when I hear myself repeat it, it's hard for me to go forward. Is there any way we can correct this?
So on our end, we're not hearing any feedback or anything. One thing I'm curious about, do you happen to have the stage open in another tab? And that might be creating some of this feedback issue. If you exit out of the social impact stage on the, not that, but in the left tab, that left tab, not the whole window. Some technical difficulties that we will figure out very quickly in a second.
There you are.
I know.
So do you only have the one tab open?
Okay, yes, it's only one. Yes.
Great. You can go ahead and share the presentation one more time. It should be awesome.
Okay. All right, I'm gonna try to make it through this. I apologize. This is technology. All right, so can you hear me?
Yes, we can hear you.
All right, so again, I'm so sorry for this. I'm not quite sure. I'm always, if something's gonna go wrong, it's gonna go wrong with me. All right, so let's see if we can get through this in sort of record time. Next slide, please. As I said before, I really have nothing to disclose. Next. And I wanted to start off the conversation by defining health I always use the World Health Organization's definition because I believe it describes health best for me. It defines it as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. We have a tendency to, historically, to define health as something to do with the pathophysiology of disease and how it affects the individual, and not look at the whole person. But the W Health Organization actually looks at the whole person, not only the physical health, but the mental, social, and emotional well-being. Next slide. So I want to talk a little bit about determinants of health because that's critically important as well. We usually start with genetic makeup, what's in your DNA, what runs in your family. That's a large part of your health, but also your individual behaviors, the choices that you make around whether or not you are able to eat the right foods or exercise or drink excessively or take drugs, all of those individual behaviors, or if you're compliant with your medical regimen, we consider those individual behaviors. And then there are the social determinants of health. Those are determinants that are beyond your genetic predisposition, beyond your individual behaviors. Next slide. Social determinants are the economic and social conditions that influence your health. WHO defines it as the conditions in which people are born, grow, live, work, and age. Next slide, please. And so they're actually broken down by categories. They start with your economic stability, neighborhood and physical environment, education, food, community and social context, and healthcare system. I just want to point out those that are probably the most relevant. Under economic stability, we look at your employment and your income, your ability to support yourself financially. Under neighborhood and physical environment, we look at transportation, we look at of your housing, we look at the safety of your neighborhood. Under education, literacy, early childhood education, which is a foundation for learning, and higher education, food, whether or not you have food insecurity or access to healthy options, whether you live in a food desert or not. Your community and social context, which is incredibly important because it really speaks to things like discrimination and racism and the stress that's encountered from that and other aspects of your life. And finally, the healthcare system. Access to affordable, quality healthcare is critically important. All of these basically make up the social determinants of health, which always impact your health outcomes. Next slide, please. You can't talk about social determinants without talking about structural determinants. And those encompass policies, laws, governance, and the culture in the context of race, gender, and class. And so when you have inequities in structural determinants, then it produces these systemic disadvantages, which lead to inequitable experiences in the context of the social determinants of health. Next slide, please. So when you look at social determinants, the impact is tremendous when to your health outcomes. But one thing that we know for certain is that social determinants are largely responsible for the health inequities, which are the unfair and avoidable differences in health status that we see within and between countries. Now, don't confuse health inequities with health disparities. Health disparities are just the differences between health outcomes. Health inequities are the unfair and avoidable differences in health status. Next slide, please. WHO defines health inequities as systemic differences in health outcomes that are closely linked with social, economic, and environmental disadvantages. And they're often driven by social conditions in which people work, live, learn, and play. Next slide, please. So when we look at children, there are a long list of health inequities that are associated with social determinants and race. I just want to mention a few of them because they're so incredibly prevalent, and they've been this way for many years, and we don't seem to be making any inroads in these health inequities. The first is low birth weight. We know the incidence of a Black child having low birth weight is 2 times that of their white counterparts. When you look at asthma, we know the incidence is much higher in the African American community, and there's a fourfold increase in mortality than whites. When you look at obesity, there's an increase in incidence of obesity in children of color, and especially Native Americans. And when you look at type 2 diabetes, which is a sequelae of obesity, in children of color, it is 2 times that of whites. Finally, if you look at behavior health, access to health, diagnosis of behavioral health disorders are significantly less in the African-American communities. And if you look at the troubling incidence of suicide, over the past 10 years, it has risen considerably in the African-American population to where it is currently 2 times that of whites in the age groups between 5 and 12 years. And if you look at oral health, cavities are up by 1.5%. Next slide, please. And this diagram sort of gives you a context in which you see how structural determinants and social determinants interface with one another. Social determinants are really sort of the driving force for a lot of the social determinants that we see in healthcare. And when we talk about structural determinants, we're talking about upstream factors that really impact one's health. And that has to do with, as we said before, the policies, the governance, the culture that we live in, racism and discrimination, which drives all of the socioeconomic forces that produce poor health. Next slide, please. So if we look at adults and the social determinants and the health inequities associated with it, we can, again, have a long list of incidences where you see a disproportionate number of people with color having increased prevalence and mortality. So if you look at cancer, we know that African Americans have the highest mortality across all cancers than any other, than their white counterparts. If we look at coronary heart disease, we know that they have a 70% increase risk of congestive heart failure and heart disease for poor Blacks. If you look at diabetes, there's a 77% increased risk for African Americans than for whites. And if you look at end-stage renal disease, African Americans are 4 times more likely to have end-stage renal disease than whites, and they are less likely to receive renal transplants. And so there's a long list of health conditions where you see a disproportionate amount of poor outcomes as it pertains to people of color. Next slide, please. So I just want to say a little bit about adverse childhood experiences and toxic stress, because they are a significant social determinant that we have been focusing on over the past, 3 or 4 years. Adverse childhood experiences are defined as potentially traumatic events that have a negative, lasting effect on the health and well-being of an individual. And it came about from a study that was conducted 25 years ago. And again, we've just sort of highlighted it over the past 3 or 4 years as if the study just came out. But this is an old study. And what they asked patients to do who were part of a weight loss program who were not making any inroads, they had to complete a confidential survey regarding early childhood experiences such as abuse, neglect, mental illnesses in their family, incarceration in their family, parent divorce or separation. And then they also assess their current health status and behaviors. And what they found is that patients with multiple adverse experiences in childhood were more likely to have multiple health risks, such as heart disease, COPD, obesity or depression, anxiety, and substance abuse. Next slide, please. And they also found that the ACEs scores, your outcomes were dose related, right? And so later on, even though this study was done in middle income, predominantly white community, they extended this to children, especially children of color. And they found that if a child has the ACE score of 3 or more, then they're 3 times more likely to have academic failure, 6 times more likely to have behavioral health problems, and 5 times more likely to have attendance problems. In adults, if you have an ACE of 4 or more, you have 7 times the likelihood of having problems with alcoholism, 2 times the likelihood of having cancer, and 4 times the likelihood of developing emphysema or COPD. And what's most striking are the mental health and behavioral health outcomes. If you have an ACE score of 6 or more, you have a 30-fold increase of having suicide, of committing suicide. Next slide, please. So let's talk about, I hope I've given you a brief background on health inequities. What can we do to address health inequities? Well, the WHO framed it better than I've ever heard. They said, why would you treat people without changing what makes them sick? You have to treat the underlying cause of an illness in order to effectively improve their health outcome. And so they convened a commission in 2005, and the commission came up with 3 recommendations of how you can reduce or eliminate health disparities associated with social determinants. The first was a pretty lofty and almost impossible task, and that was to improve the daily living conditions of everyone who are impacted by the social determinants. The second was even more difficult, and it said we need to tackle the inequitable distribution of power, money, and resources throughout our communities. And the third was that we should measure and understand the problem and assess the impact of the action on a daily basis. And that's something that, as physicians, we have tried to undertake. And so I'm just going to briefly go over what some of the roles have been and what the roles should be in order to address health inequities. Next slide, please. So for physicians, I call it an expanded role. We have to consider our impact and leverage our position outside of our offices and the exam room. First, we need to identify and address the problems associated with the social determinants. And that's, that requires that we have routine screenings during our routine periodic assessments. In our clinic, we develop a family resource survey that really addresses every social determinant of health that impacts our families. And we administer this survey for every well-child visit every year and several times during the first year of life. The second is that we need to promote patient education and empowerment. Our patients need to start taking ownership of their own health, and we have to prioritize things like health education. We have to promote patient self-management, and we have to incentivize healthy behaviors. Third, we need to advocate for system changes. Changes within the community, such as access to healthy foods, community gardens, green spaces for our children, all those community-based initiatives that we know have a positive impact on health. We need to support family support agencies and organizations in order to build resilience. And we need to advocate on the policy level for things such as universal pre-K and universal healthcare. And finally, we need to provide leadership in health reform, not only on the national level, but on the local and the statewide level as well. And in that, we need to include health promotion and prevention, social services, mental health services, education, and housing standards, which really are not routine for just a healthcare provider, but we need to extend our reach in order to improve those factors. Next slide, please. The federal government, of course, has a role, and they've actually been fairly active over the past 10 years, especially with the passage of the Affordable Care Act. One of the things that really focused on was increasing access to healthcare by expanding insurance coverage and also expanding safety net health centers, such as community health centers. They've been working on increasing workforce diversity and cultural competency for medical providers. They've done a lot around prevention and public health initiatives, especially around supporting the CDC. And also they've really worked hard on impacting social and community provisions for families, especially through the accountable health communities, which really connects patients to community services for social support. Next slide, please. On the state level, we've done a lot. Unfortunately, in our state, we haven't really tackled the issue of expanded Medicaid, but in majority of the states in this country, they have expanded Medicaid in order to increase access to healthcare. A lot of the states have really instituted a fairly robust chronic disease management program. They've been focusing on improving immunizations. And especially in our community, we've had a lot of focus on vulnerable populations, such as the homeless, children, and refugees. We have a lot more work to do. There are a lot of things that have sort of gone undressed, but I think as a community at large, both federal, state, and individually, we need to really focus on education, on housing standards, on employment and income, and also on all the structural inequities that we talked about before, such as the policies that govern how we provide healthcare and how we see individuals, the laws that we pass, and the governance. Next slide, please. So, the onus is on all of us, right? Not just one entity, healthcare providers, federal government, state can do this. All of us have to participate in building health equity and addressing health inequities. And so I put the slide up because it really sort of signifies how community is so important in actually addressing this problem. And I'm having a hard time some of the headlines because it's so small, but one thing I want to point out is that on the left side, when it says when inequities are high and the community assets are low, then health outcomes are the worst. And you can see how they're pronounced in this particular tree. But when you build up community, when you address things like income inequality and racism and jobs and all of those things and good schools, then you actually you improve the health outcomes for the community, and you don't have as much prevalence as all of the disorders that you see on the left side. Next slide, please. So I'm going to end this by stating a quote from the Reverend Dr. Martin Luther King, who says, "Of all forms of inequality, injustice in the healthcare is the most shocking and inhumane of all." And so as always, you know, when he has all of these wonderful quotes that we commit to memory, it's not just to commit to memory, but it is a charge for us, for all of us. And it really signifies that in order to battle inequality in healthcare, it requires all of us participating in various ways, whether it's through providing medical services or creating policies or creating systems of care. It is all up to all of us in order to address health inequalities. And with that, I'll stop for answers. And again, I apologize for all of the mix-ups initially. I can't hear you, Anshu. I can't hear you.
Sorry about that.
It's okay.
I know we just have 1 minute, but to take a quick question from Alexandria, she asked, how do you think about ACE, adverse childhood experience scores, as they relate to social determinants of health?
Oh, it's one of the, well, the scores, well, adverse childhood experiences represent trauma and toxic stress, right? And that is one of the premier social determinants of health. And so if you can address the toxic stress of childhood and even of adulthood, then it can it can improve your health, right? And so in order to actually think about addressing social determinants of health, you know, you have to, I think one of the first things you have to do is look at the experiences that people have throughout the course of their lives that impact their long-term outcomes. And we know that ACEs and toxic stress does impact the long-term health outcomes of an individual. And so you really need to start addressing that early on.
Awesome. Well, we have hit 10:30, but thank you so much, Dr. Johnson, for the very enlightening presentation. I'm sure our audience really, really appreciated it. So thank you so much, Dr. Johnson.
Well, it's my pleasure. And again, so sorry for the technical difficulties. It always happens to me, I have to tell you.
No worries. Thank you.
All right.